Assalamu alaikum. Eid Mubarak. Good morning, good afternoon, good evening, wherever you are. It's my great pleasure to welcome you all in the 63rd edition of the MENASO Educational Academy Cerebrovascular Grand Rounds. And the third event for this year. This is the third webinar, which is done in collaboration with the SVIN group. We are very honored to have a very distinguished speaker tonight from US and from Saudi Arabia. This session focused on bridging evidence and reality in rescue EVT, and it's a combination of didactic and some practical tips, and some cases will be shared. Last year, this webinar series was attended by more than 5,000 participants. So we really appreciate you being with us, and their participations were from all over the globe. This was only made possible with collaborations with different societies and with the distinguished speakers, such as the ones we are having with us tonight. We are pleased to bring together this group of international and regional experts, and with the attendance from all over the globe. But before we begin, I just would like to take a moment to acknowledge with deep sadness the passing of Professor Niels Wilgren. He's well known, a true pioneer in stroke medicine and inspiration for generations of physicians and researchers around the world. As a professor emeritus at the University of Karolinska and previous stroke program director at the University Hospital, his leadership played the defining roles in shaping modern stroke care globally. And through his establishment of CIS registry, he helped into the implementation and standardization of stroke care, not only in Europe, but globally. And he had significant contributions to our region and to MENASO activity through his role in establishing the MENASITS program, supporting regional research, which resulted in few landmark papers. He was a visionary leader, a dedicated mentor, and generous supporter of global stroke community. And on behalf of the MENASO and on the entire stroke community, we extend our heartfelt condolences to his family, friends, and colleagues. Now I would like to take this moment to welcome my co-moderator, Dr. Ayman Quaitin, who is a distinguished interventional neuroradiologist, well-known in the region, and he's currently practicing in Sheikh Shakhbouta Medical City. And before joining us he was working in Ontario, Canada. Dr. Ayman, kindly introduce yourself, and the mic is yours.
Thank you, Dr. Adel. Thank you, everyone. Assalamu alaikum. Today we'll be basically exploring bridging evidence and reality rescue EVT with Dr. Romal Singh, who will be presenting recognizing and treating ICAD during thrombectomy. We will also have Dr. Al-Hamza Al-Bayati, who will talk about rescue strategies for intracranial atherosclerotic disease in acute large vessel occlusion. Also, we have Dr. Abdullah Al-Rashid, who will present rescue EVT in resource variable settings. And finally, Dr. Mohammed Al-Hajmi will talk about cases of rescue stenting and angioplasty in clinical practice. These are very highly relevant topics, and I'm sure you'll find them both insightful and informative. Regarding the question and answer session will be after the last lecture. We'll start by introducing Dr. Romal Singh. It's my pleasure to introduce our first speaker, who will present recognizing and treating ICAD during thrombectomy. Dr. Singh is a vascular neurology fellow at the University of Pittsburgh Medical Center. His interest is acute ischemic stroke, endovascular therapies. He completed his medical training in India, followed by research in critical care at Mayo Clinic and neurology residency. His work focuses on stroke systems of care, imaging of reperfusion therapies, and neurointerventional outcomes. He's actively involved with SVIN initiatives and will begin a neuroendovascular fellowship at the University of Miami in 2026. Welcome, Dr. Singh. The floor is yours. Thank you.
You guys can see my slides?
Yes, we can.
Okay. Hello, everyone. My name is Romil, and I'm one of the PGY 5 Vascular Neurology Fellows at University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. I work under Dr. Al-Hamza Al-Bayati, who I have to thank for providing me this opportunity to present this case that we both were involved in. And thank you for all the other moderators and people who organized this conference. Thank you so much for inviting me. So basically, I'm going to present how should we recognize and treat ICAD during thrombectomy and about a rescue case. So here we have a 49-year-old female who has history of Leigh syndrome, which is a chronic arteriosclerotic disease involving the peripheral arteries as well as the central arteries. She also had history of hypertension, hyperlipidemia, and tobacco use disorder. She was admitted to vascular surgery service with bilateral leg pain, with chronic burning and fatigue in the lower extremities. She underwent bypass in the past last year, aortofemoral bypass. Unfortunately, still was having a lower extremity claudication for more than 1 year. She was literally housebound and unable to travel by herself. And the previous attempt was not successful due to chronic occlusion with dissection. So she was admitted again for an elective aorto bifemoral bypass at the outside hospital. So first day, she was admitted to the vascular surgery service and underwent the bypass really well under general anesthesia. It took around 4.5 hours. She had 16 to 8 bifurcated vascular graft to the aorta. In terms of anticoagulation, she received intraoperative heparin and prophylactic antibiotics and some local hemostasis. Overall, the procedure went without any complication, and there were no documented intraoperative complications from the note reviews. And pre-op, in terms of neurological examination, she was alert, awake, and without any focal neurological deficits. And in terms of neuromonitoring, everything was okay. Similarly, in terms of post-op documentation also, no neurological change was noticed. Even in PACU, she was perfectly fine. However, unfortunately, day of hospitalization, day 2, around 1 p.m. Eastern Standard Time, she was found to have a right-sided facial droop, decreased responsiveness and aphasia, with the last known well time of around 10 a.m. So UPMC telestroke service was consulted for a possible stroke occurring in the patient. So basically, when UPMC telestroke is consulted, we usually, as a fellow, take care of around 40 odd hospitals from all the spoke centers around Pittsburgh and the surrounding states. The attendings and the fellows from other places, they consult us for a possible telestroke evaluation. So that's when I went ahead and saw the patient. When we examined the patient during that time, unfortunately, the patient's NIH score was 22, which was really high. She was unable to answer any of our questions, unable to follow any commands. She had a right-sided facial droop. She was completely plegic on the right upper and lower extremities. Right upper extremity, she was having much more weakness compared to right lower extremity. There was some weakness in the left lower extremity as well, which we were not able to 100% tell. Is it because of post bypass or something else was going on at that time? She also had right hemisensory loss, aphasia, dysarthria. So the patient underwent imaging over there, which I'm going to discuss in the next slide, was given an aspirin load and was transferred to our facility because of what was happening. In terms of the CT head, uh, just a normal looking CT head going from up to down. Usually with the NIH scale of that high with 22, we are looking into left MC or a left ICS syndrome. However, if you look here, we were not able to see any gray white matter differentiation, at least in the outside hospital, maybe subhypodensity in the left MCA territory, but we were not really sure if something we can make out of it. Was a very, very early change that was noticed by the nursing staff with the last Manuela around 10 a.m. And within 3 hours, they noticed the change and then put the patient for vascular imaging. In terms of the angiogram, though, when you look at it, going from bottom to top, if you look at the left, and I'm going to pause here for a little bit. Here you see hopefully you are able to see my mouse pointer. Here you see the left IC and the right IC. The left sided of the entire patient's vascular territory, the internal carotid artery as well as the external carotid artery, they were all very stenosed. And we were not able to see an acute clot. But if you go up here in the MCA territory, and let me pause it over here. Right here, there was a cutoff in the left MCA, right, coming from the carotid terminus going into the MCA. However, there was some distal flow. So with UPMC system, we have the advantage of following up a CT angiogram with a CT perfusion study as well. So just to briefly discuss about how the CT perfusion, we use Viz AI software. And basically, we look into three different specifics of Viz AI, which is known as the CBV, the CBF, and the MTT. CBV is the cerebral brain volume. It's the total volume of the blood present in the given volume of the brain tissue at that particular time. The blood can be present in the arterioles, capillaries, and the venules. It just reflects us that if the auto-regulation of the body is going on pretty well, and if the brain is able to compensate for it or not. In terms of the CBF, it is known as the cerebral blood flow. Is the total volume of the blood passing through the given volume of the brain tissue per unit time, measured in millimeters per 100 grams per minute. And this is our flow rate. When CBF drops significantly below 30% of normal, that basically means that in layman terms that our tissue is in trouble and there is ischemic penumbra. More than 30% should be ischemic core given by our CTP software. However, the one thing that I want to mention and we should focus on in this case is the Tmax, because in ICAT studies, Tmax is the time to approach maximal blood supply in that particular area of brain, which is a delayed parameter, shows that it is the time to peak the residue function of deconvolution analysis. But practically speaking is how delayed the contrast arrival is in one side compared to the other side of the brain. So let's play this video and see if this patient is having a difference of a CBV, a CBF, or a Tmax in CT perfusion. So if you are able to see CBV and CBF pretty much are aligned on both sides, but on the bottom left part of the screen, the Tmax is much more raised. The blue column is where there is normal blood supply, but wherever it goes to light blue and more towards red, it's showing ischemic blood supply and a delayed perfusion. However, the CBV and CBF are not affected yet because the brain is able to auto-regulate a little bit and might decompensate later on. So that's what we saw in terms of Tmax for this patient. Going ahead with the Tmax analysis, we have seen studies in the past that Tmax more than 6 seconds from the Dawn and Diffuse trial done 10 years ago. That is what we account for the core, which is the ischemic infarct that is happening. And the green part would be the penumbra that you can save. But Here is a large territory, basically the entire left ICA territory, which accounts for the blue part, which is the 4 seconds, which is not been noticed to have any kind of ischemia. However, as we discussed in the past slide with the Tmax, that it has been shown in ICAT population that if you have a Tmax of greater than 4 seconds, which is 183 cc's here, that links us to that there may be some kind of ICAT process going on. So this is one takeaway that I can give you from my presentation, that if you have benefits of having a CT perfusion at your hospital systems, and if you are suspecting an ICAT, so basically looking at all the parameters really help us out. Patient was transferred to UPMC Comprehensive Stroke Center and was taken a look by Dr. Albayati over here. Going ahead with the CT head when the patient was transferred to our facility. Again, there is some artifact going on, but I don't see any big infarct that is forming. However, the patient is much more symptomatic, even though there is no big infarct forming over there. As I was pointing out to the ischemic lesion over here in the ICAD territory, entirely in the left ICA leading into the MCA. It's a very tapered branch going from the carotid terminus to the M1 segment. However, in the distal, there is some blood supply. Again, in terms of the core and the penumbra, there was only 2 cc's of cerebral blood flow, less than 30%, and there was a very high penumbral tissue that we could save. If you compare it from the last slides, the penumbra has become much more. That means that the body is trying to shut down the autoregulation, but still we are in the way of that. We can treat the patient, and possibly a patient will be able to recover very well. But a great volume of mismatch to go ahead with the thrombectomy. So patient was taken to the IR suite, and a right radial approach was used. With the right radial axis, an ultrasound guidance, a 6 French slender sheath was placed. Hopefully these videos will play. So if you're looking on the left slide, I'm going to go a little bit slower. Here is the common run where you can see, and I'm going to pause. You can see right at the carotid terminus, there is an occlusion. We are not able to see anything distal to that. And this is the AP view on the left side. And if you go into the lateral view with the common run, you can see the ECA territory arteries overlooking the ICA terminus. And the ICA terminus ends up over here, and we're not able to see any MCA vessels. So these were the first runs to keep in mind. Then we took a triaxial system and we navigated intracranially. A Trevo 6 by 37 stent retriever device was placed in the left MCA territory across the thrombus, and with a Zune 7X contact aspiration catheter, resulting in a successful recanalization of left MCA TK2C, and there was some improved blood flow in the ACA, which is TK2A. However, there was some mild residual ICA stenosis which still remained, and I'm going to show you just that. So even if you see here, even there is after the Trevo track that we used, there is some area of possible clot or an ICAD lesion, but still better as we are able to see something distally in the M1 and M2 territories. Let's play a little bit again. And similarly in the lateral view, there's a little bit flow. However, so we try to think about in these cases that this is likely an ICAD lesion, and we need to wait 5 to 10 minutes more after we do a stent retriever to see if it remains open or not. However, following up angiography showed that it shuts down again. So see the lumen that completely breaks down between the ICA terminus M1 segment and the M1, M2 segments. It completely breaks down again after 5 minutes. And similarly in the lateral view as well. Then our IR team decided that given that after repeated passes and using a stent retriever Solumbra technique as well, it is shutting down. So we decided to put a stent in the MCA territory because we thought that it is likely an ICAD lesion, which was collaborating with the CTP findings that we saw before. So these are just mentioning the dimensions of the stent. And then we put about the Onyx Frontier 2 by 15 stent, as you can see on the left side in the AP and on the right side in the lateral view in the ICA terminus in the proximal M1. So these are the static images of the same. And you see how much better it is looking after the stent. There was no residual flow, as in like the slow flow into the MCA territories. The arterial flow changed into capillary, then changed into venous flow. So no more slow flow was recognized after placement of the Onyx stent. And the post-deployment demonstrated complete MCA reperfusion without in-stent stenosis, as I was saying, with TK2A in the left ACA territory and a total of TK2B more than 67% reperfusion in the left MCA territory. So comparing to the pre and the post, pre is on the left side and post is on the right side. We see that the patient has good amount of blood supply in the entire MCA territory. However, if you are not able to place the stent or our IR team was not able to recognize ICAD lesion in the first go, it would have kept on shutting down with just contact aspiration. Similarly, on the lateral images, the pre is on the left side and the post on the right side, showing how much of an improvement angiographically happened in the patient. And the final findings just showed that there was some slow flow in the ACA territory, along with the MCA territory, which showed successful recanalization. The patient had less than 20 cc's of blood loss. Eventually, because of the spasm caused by the entire procedure, patient received some verapamil, was given aspirin, and was started on integralin drip. That's what we do here after putting an intracranial stent in. Some people use Cangrelor as well. Post-procedure patient was admitted to the ICU, and as soon as the procedure was done, post-extubation, once the resident examined in the evening, patient was able to have anti-gravity movements in the right upper and lower extremity. So just showing how much damage was done, how much objective damage was done in the brain. So this is the DWI images. If you see, there are some small distals in the entire MCA territory, but no major core infarct that you are able to see because we were able to recognize the ICAD lesion and were able to treat, IIRT were able to treat with the stent. The patient was discharged within 6 days, and recently I saw the patient in 2 months afterwards his discharge, and this is the documented exam. 5- strength on the right lower extremity in the motor section here, and normal tone in the upper and the lower extremities with normal movement, and completely normal sensation. She walked in. So this is a great recovery that we were very excited about, given how the patient presented in the first go. So just my last slide showing the learning points from a fellow's perspective is that if you see a tapered occlusion, we are always worried about a dissection. But if we see residual stenosis or when you are doing a thrombectomy and the reocclusion keeps on happening, that should raise a suspicion for an ICAD lesion. After successive passes, you are able to see distal flow, but you wait 5 to 10 minutes and then it keeps on collapsing. Then it's very high likelihood of ICAD lesion as well until proven otherwise. Wherever you have CT perfusion, I know not all the hospital systems have it, but wherever you have taking increased amount of Tmax as penumbra is not always the same. You have to keep the entire patient's holistic perspective in motion and see if the Tmax of more than 4 seconds compared to 6 seconds is more, and if it's matching what the patient is having an issue with in terms of the ICAD, which was in this patient. So interpretation of the perfusion is in context is very, very important. and early recognition with a great outcome with the good perfusion is the way to go. So we were very happy with that outcome in both categories in terms of how much the amount of stroke the patient had, what the recovery was, and how IR went. So that was my presentation. I'm going to stop sharing and open for questions. I believe we are taking questions at the end.
Thank you very much.
Thank you so much.
Thank you, Dr. Singh. This is for the very interesting presentation. Yes. Any questions, please write them in the question and answer section, and we will answer the questions after the last lecture. Now we have our second speaker. I would like to introduce Dr. Abdullah Rashid, who will present rescue EVT in resource variable settings. Dr. Rashid is an accomplished interventional neuroradiologist with a strong educational background. He is Saudi board certified in radiology. He has extensive training with fellowships in neuroradiology and interventional neuroradiology from the University of Toronto in Canada, also a fellowship from King Fahd Medical City in Saudi. He held significant roles, chairman of neuroimaging and interventional department and head of diagnostic neuroradiology section and subspecialty consultant at King Fahd Medical City in Riyadh. Welcome, Dr. Rashid. The floor is yours. Thank you.
Thank you. Second, allow me to share. Right. First of all, thank you, Dr. Adil and Dr. Ayman and MENASO for the invitation. In this short talk, I will share some thoughts and experience with you regarding the rescue EVT in resources limiting or variable settings. Nothing to disclose. We'll talk about the scope of the problem. We'll see if we can identify ICADS, LVO, and what will be our strategy in those situations. Well, the failed mechanical thrombectomy rate is approximately 10 to 15%. In the best centers, it can go up to 25% in more complex real-world cohorts, and it doubles the 2 times the higher rate or higher mortality rate. The causes of refractory LVOs most commonly is ICAD, and then sometimes we see dissections, and if we have a difficult clot like a calcific or fibrous fibrin-rich clots. ICAD LVO account for 10 to 30% of all LVOs undergoing mechanical thrombectomy, depending on the vascular risk, age, and ethnicity. Okay. Well, the first pass effect is negatively associated with underlying ICAD, of course. So it's very important to make a good strategy approaching those cases, weighing the procedure risks like vessel injury against chance of functional recovery. Factors such as the age, collaterals, and onset time predicts treatment outcome. Always multidisciplinary approaches are helpful with the dynamic assessment during the procedure to enable tailored treatment plans. Just a quick slide about some, I think, helpful tips to identify the ICADs before the procedure. If you see check your CT and there's no hyperdense vessel sign. If there is a history of strokes or all strokes in the same territory, sometimes it's an indicator of an underlying ICAD. If the patient is known, having known case of intracranial atherosclerotic disease, if you see other vessels with atherosclerotic changes, ethnicity is also very important in our region. If you see ICA terminus occlusion, as we saw in the Dr. Rommel case, if it's a ICA occlusion, it will be 40% chance of being an ICAD as compared to the cardioembolic occlusion. During the procedure, if you see a truncal type occlusion pattern, that's like a good indicator, a clue to helps you to predict that this is most likely an underlying stenosis. If you have remnant fixed focal stenosis after recanalization, if there is a immediate reocclusion after clot retrieval, if you don't get any clots in the stent, if there is a slow antegrade flow despite the recanalization, if you have multiple passes, usually more than three passes or attempts, which is the first pass effect. And I think if you do more and more of those patients, you will be able to feel the lesion during the crossing with your microwire and microcatheters, some resistance, some frictions. Even if sometimes if you pull the stent retriever, you may feel some a cracking or like that the stent sometimes has a little bit resistant getting out of the patient. So what do we do if we have limited resources? In general, we have two things to do, and pharmacological options like GB2B3A inhibitors, intraarterial TBA, and dual antiplatelets therapy. We will focus on the endovascular options. Depends on your approach to the case. If you start with aspiration alone, which is like a good idea and wise option to do if you have a limited resources. If it fails, then you switch or you combine it with a stent retriever. If that doesn't work, prioritize angioplasty, submaximal angioplasty, with the advantage of avoiding the dual antiplatelets and the cost of the stent. Then if we have to do it, we have to do the stenting eventually using self-expanding stents like the Wingspan or the like relatively more recent stent like a Neuroform, or combine both. Okay, so as we said, prioritize angioplasty with the benefit of avoiding the dual antiplatelets. And especially if you have like a higher risk of hemorrhagic transformation, like of a patient with low aspects, and you don't want to put them on dual antiplatelets, you can use non-drug-eluting, non-drug coated balloons like Wingspan, or a little bit more expensive drug-eluting balloons. Yeah, you can choose they are readily available coronary vials of Agrostat or Integralin, and avoid using more expensive agents like Cangrelor if it is available. Then eventually, this is the good option of using a two-in-one approach to those lesions using coronary balloons off label, of course, but a lot of publications showed that it works very well and with a high rate of successful technical success and less complications. This is we use it more frequently now in our institution. This is just a quick case showing the proximal or M1 occlusion. This is after the first pass with the stent retriever. You can see the M1 is recanalized with some residual stenosis. You notice some delay in the flow despite of recanalizing the occlusion. This is a more delayed angiogram showing still there's a significant delay in the antegrade flow. One pass of angioplasty, simple angioplasty was done, submaximal. Then this is the final result, the delayed angiogram after 10 minutes, showing no restenosis, excellent antegrade flow as compared to the pre-angioplasty angiogram. More recent case we did last week, showing this occlusion of the M1. Actually, the patient was moving, but it's not as we described, it's not a truncal type of occlusion because there are some contrast going down here. So we tried 3 passes of stent retriever and combination with the aspiration catheter using large bore catheter, but after 3 passes we could not get the clot. So she is a young patient with a good aspect score, high in IHSS. Sometimes the cost doesn't matter because you are saving her basically life or function. So we did like a salvage technique with double stents. One stent in the superior division and the other one is the inferior division. Combined with direct aspiration, we managed to get a large clot, partial recanalization, but we got good TK after additional pass with a smaller stent to open up the distal occlusion. So in this case, we did not save money, but we have to do it because you have to do it. It's everything is in favor of the patient's good outcome. So when to stop? If you have a constrained environments, practical approach should be emphasized. A stepwise approach is also a good thing to consider. Don't not recommended to exceed more than 3 passes because eventually it will be of a low yield. Recognizing the lesion early helps, like we showed in the first case, and immediately recognize that this is an atherosclerotic stenosis. Then just go do the angioplasty directly, see if it works. If it doesn't work, then you can upgrade your approach to permanent stenting using also antithrombotic agents as per your protocol in your institution. Okay, thank you very much.
Thank you very much, Dr. Abdullah, for this excellent presentation. Again, we will leave the questions to the end. And it's my great pleasure to welcome Dr. Al-Bayati. Dr. Al-Hamza Al-Bayati is a close friend, and he's an associate professor of stroke and neurovascular surgery at the University of Pittsburgh School of Medicine, and he's the director of the co-director of the pediatric stroke program, pediatric neuroendovascular surgery, and surgical co-director for Neurovascular Center of Excellence at UBMC Children's Hospital in Pittsburgh. His clinical and academic work focuses on advancing treatment of ischemic and hemorrhagic stroke across the lifespan, with expertise in complex endovascular interventions, in particular in pediatric cerebrovascular disease and acute stroke therapy. He's also actively involved in the national and international research and been of like great assets to our regional meetings. So we appreciate his presence and dedication in training the next generation of stroke neurologists, not only in US and neurointerventionalists, not only in US but global. So, Dr. Hamza, without further ado, the floor is yours.
Thank you very much, Dr. Adil and Dr. Rashid and the whole organizing committee. Really appreciative of the opportunity. Let me try to just really quick here. 1 second. I disclosed with the colleague who was texting me. I had like my slides really got messed up the whole morning, so I'm apologies if anything kind of get projected here in a bad way. I hope not the case. Alrighty. All right. Do you guys see the slides moving?
Yes.
Okay, perfect. So again, thank you very much. Let me just get the making sure laser pointer is working. Do you see the laser pointer working as well?
Yes.
I
Yes.
hope. And then eventually we'll have to change to not that. Okay. So thank you again. And before I start, something that I really want to get out of my chest and speak. I've been very vocal and can't hide my emotions, honestly, with this challenging time of the region. So all my prayers and really praying hardly on all the victims. And I don't know, it's a very challenging time of our nation and our region. And I pray God that bless you all and يثبتكم وبردا وسلام إن شاء الله على الخليج الحبيب. So I really have, I'm kind of struggling these days, but I really wanted to get it off my chest right off the bat. Just jumping in, try to kind of make it interesting to the audience. Didn't want to bore you with like numbers and stuff. So just try to briefly go over what we're going to talk about. Dr. Rashid, they did a great job, and Romil kind of also touched upon all the metrics and how is this disease, and we emphasize on this disease because it's not your bread and butter thrombectomy, right? We're talking about a completely different beast here. And it's also not the elective situation, which a lot of people would argue, like our Sampras, and we get the weaves of the elective intracranial stents and bypass and all this kind of different situation. This is what we call you're having an MI that you have to acutely put a stent in the heart. This is like all hands on deck. You have to treat this patient, keep the blood vessel open no matter what it takes. That's like the unique situation, not a typical thrombectomy, not your typical someone who's coming from home with TIAs and quote unquote failing medical management. This is not Sampras prototypes or visit or whatever intracranial elective revascularization, or the Eastern world with the Chinese population or the Japanese population for subacute bypasses, right? These are like acute revascularization when you have a large vessel that's blocked and you turn to be not regular occlusion. It's related to intracranial atherosclerotic disease, and that's why it's significantly change your management on the table, and also at least the subacute version in the hospital, how things are completely different than a different patient, and obviously long-term sequelae with controlling risk factors, because these patients will have more vulnerable lesions in their brain, obviously. So recognizing that, recognizing the angiographic, and then how do you stepwise, right? And I'm gonna be very honest here. I personally have evolved with this type of population a lot. I used to kind of try, stay away, don't kind of fear, for lack of a better term. Like, you don't want to put a stent, you don't want to load the patient. What if you rupture? What if you dissect, etc.? Until I got burned with this reocclusion, and then you rush them 2 in the morning to do exactly what you could have done 6 p.m. or 2 p.m. Not that we have to be more aggressive, it's just kind of recognizing and be more patient to stratify who's these patients that potentially can get worse. And then try to, at least what I tell Romil and all the fellows and the residents, it starts with me before anyone else. I have to create some sort of a structure before you just, today I do this, tomorrow I do that, this medication, this stent, and try to have some sort of a structure to it. And again, for the sake of time, this kind of slides may be busy with numbers and stuff, so I'll go through it because Dr. Rashid eloquently put some numbers and shared some information already, and Romil as well with the imaging. But yeah, it's an intracranial occlusion. It's not your typical embolic. It's more common than we think, obviously, more so than in our region, in the eastern side of the world with the Asian population. Even the Western cohort, when people having more diabetes, they're living longer. That's a start, right? The people like you have better cancer treatment, better preventative measures. So the odds of you living longer is higher, which means the odds of you potentially developing obesity, kind of diabetes, other metabolic risk factors are higher. Unfortunately, African American or Hispanic definitely have more genetic predisposition to that. And then typically, again, as we said, without rescue intervention, you will have higher risk of reocclusion. This is a nice paper that kind of think about this. We always tell the patients and the trainees as they see me in the rounds, any stroke, the 20-foot view of a stroke, we always have to tell the patients or their family, is it a pump problem, a heart? Is it a pipe problem? Is it like the blood vessel? Or is it the actual liquid in these blood vessels and the pipes, which is the blood, right? So these are like the X's, came across this figure. So again, you can tell, this is not going to bore you with this, but makes sense when you kind of simplify things. And then the target here is the inside of thrombosis. You can only have stenosis that eventually will have a hypoperfusion or a flow failure that will end up causing you the damage beyond that spot. Or you have this inside of thrombosis. On top of that, you slowly kind of create clots, fresh clots sitting there, and either dislodge and go distally and cause you to have a more of a beyond the lesion problem, or just like an actual stenotic lesion. That's that one, dehydration or kind of cancer status or whatever that make you hypercoagulable state, your blood is going to be thicker than usual. This checkpoint will be kind of more vulnerable spot. Again, too much kind of information about the plaque and disruption, but essentially these are mostly platelet activation, hence the antiplatelets, the IV form or the PO form, and eventually what's going to be the most important treatment, and to one, keep the lesion open or try to prevent from recurrent events, or two, after you rescue treatment, to keep that area healthy. This is adherence to antiplatelet regimen, and preventing thrombus provocation with these antiplatelets is significantly important. So what happened? How do you recognize this, right? Why is it not like a hard clot? Why is it not a calcified clot? Yeah, I always wonder this. And I had some patients not something to be proud of. I had like 6 and 7 and 8 passes. And then you start kind of realizing, yeah, you read about this, you see it, but like, yeah, you know what? I'm getting stuff out. Maybe this is just a clot that's hard to get out. Let me do another pass and let me do another pass. And then this kind of narrowing, this is what kind of you have to look at it and carefully, especially if you get better results and then get worse. That's your hint. Whatever we just show in that graph, that kind of nasty lesion, that's platelet full aggravated lesion, potentially every time you do the stent or an aspiration pass, you might kind of activate or disturb that area and makes things even furtherly worse. That's smooth tapering, and I'll show you. Here's the nice picture here, right? So it's not necessarily like we always tell folks this kind of flame shape or how is it looking? Think about it. You can have well, some people call it pencil, some people call it tapered minuscule, all sorts of like nomenclature to describing an area that's kind of significantly narrow. You can call it whatever you want, is essentially the blood trying, or the contrast rather, on angiogram, trying to kind of seep through this area. Let me actually make sure. Trying to seep through this very slowly, and then eventually will end up opening up afterwards. So at the end, you're just describing this as a smooth tapering, concentric, whatever the nomenclature is, not your typical kind of embolic looking. And the mismatch of the collaterals, right? Sometimes that tells you, oh wow, you have like an proximal M1 occlusion, but you have the ACA coming very nicely. That tells you this didn't happen an hour ago. This is probably a lesion or a disease that's been recruiting all these collaterals over a period of time. So how to deal with it, right? I used to, and that's the beauty of the field. It's keep evolving, and we all, as operators, also keep evolving, right? So I used to religiously do stent reaver every single time, and balloon, and every pass takes 5 minutes, and inflate the balloon, etc. With the navigation of the newer generation aspiration catheter, I personally have evolved and start using more and more of these aspiration catheters. This, however, the disease, the ICAD, if you suspect it on a CAT scan, as Romil showed, this is one of those that you really have the upper hand if you put the stent reaver technique first. Why is that? Because you're going to have like almost like a free pass or probing the lesion, right? Like you're going to rehearse, you're going to pretend that there is a stent there and how it look like if you drop the stent. So that's like a kind of a freebie or free pass in that area. And then if nothing came out, that tells you that, okay, just that stent reaver just slid out of this area slowly and didn't capture anything. This, however, on the aspiration, you can say, well, I didn't get anything out because maybe I wasn't fully engaged. And then you do a second or a third pass and you start kind of push this harder and disturb this area. I've seen it in conferences and literature. Potentially you can dissect or even, God forbid, perforate the vessel, thinking, well, I wasn't very close to it, let me just be harder, etc. So I think this is one of those that I religiously go and put a stent reaver every single time I suspect an ICAD lesion, just to get more information while I'm doing the stent reaver pass, basically. Again, recognizing it, confirm the patency, give this, and we'll talk briefly about it. I don't want to spend too much time, but we'll try to you try one of these glycoprotein 2b3 inhibitor bolus by the anesthesia, and this is all about preparation, right? In parallel, while you're doing all these steps, well, this could be ICAD, I'm going to do a pass, I'm going to put potentially ask anesthesia team to whether I'm going to intubate or not. So there are so many variables that we can think out loud about them. But in preparation, you have to kind of have things, at least in your repertoire, thinking about it. What's the weight of the patient? Has the patient been on aspirin before? Did they give? Sometimes outside hospitals, like Ramil mentioned, they are ahead of us. It's like, oh, and the stroke team's like, yeah, you know what? This could be an ICAD lesion. The CT looks good. There's no big aspect, like a drop. The aspect is decent. Let's give aspirin, Plavix loads. Sometimes patients do come to us with already loaded. So all this information is very informative to at least think about before kind of start thinking on the spot and confirming what's your suspected all along, basically. Again, there's this kind of, this is the same paper. I advise the audience to look it up. It's very nice kind of algorithm. If you're thinking embolic, if you're thinking ICAD, what's the rescue, how many passes do you do, etc. So these are like things that I'll try to summarize at the end before we finish. But yeah, you can see very kind of fluid. You can have many people do different things and they get burned in a good way or in a bad way, as long as you keep all kind of the options in your mind. We talked about the GP2/3A inhibitor. Again, it's very reversible. There's a half-life, short half-life, so you can bolus it, and it's gonna go out of the body soon. So either you start transitioning to the PO pill, like the version of antiplatelets, or bridge them until they have enteral access, for instance, patient intubated, or actually intubated is not a bad thing because they can put an OG and easier access, but patients kind of awake, hating the NG, etc. So I actually got burned in the past. They spent hours trying to get NG and nobody tell us. I wish I knew, so I can bridge with the 2B3 inhibitor infusion in the meantime. This helps you a lot. And the dosing, again, these are not stuff that we have a lot of literature about in the cerebral world, right? Everything mostly cardiovascular. As Dr. Rashid mentioned, some of these stents are borrowed from our colleague from the heart department stuff. So typically, my kind of very crude way of looking at it, it's 18 to 25% milligrams or microgram per kg IV. The anesthesia colleague give it. This is your maintenance. I try to stay away from the maintenance because I'm just sometimes these infusions could be overshooting, or like the nurses are busy in the ICU, they might keep it longer than we want it to be. So I try to, as much as possible, to do the bridge very quickly post-op. So stay away from the infusion as much as possible. And then again, if you have like anything we do in the neuro world, we have to remember about the kidneys and the nephrotoxicity in general. And then if that doesn't work, then you have like the essential next step, which is the balloon. And I'll show all this again. I'm not a big fan of too much writing on a slide, but I wanted just to put it out there for the audience so they understand where we're coming from. There's so many, again, nuanced. We always say the undersized technique, underinflation. Why is that important? Because you don't want to assume that, remember, we're all humans and we do these measurements on a machine, okay? So the machine might not be as accurate as we think we are. Hence, if you, especially on a tight lesion in the M1 or an M2, I've definitely put a stent in a P2 or an A2. You want to give yourself like this kind of little bit of a buffer, if you will. So always underinflate and slowly underinflate. Pause for a second. I'm not a big fan of like multiple inflation deflation because one, potentially you might not see the balloon fully deflated and you start kind of go up thinking that, oh, well, I don't see it. And then next thing you see, God forbid, is a big rupture, right? So try to be as accurate as possible, use a longer device as possible. So you go one in and out. Sometimes it's not getting better. Then you do it multiple times. Just being very aggressive up front sometimes is not a good idea. And the wire access, you have to keep your wires so in case you need to put rescue stent and prevent perforation if this happened, basically. Stenting, again, you start with the infusion of the medication, you try the balloon, and then you do. I rarely, although there's good amount of data to support in certain occasions, you just get away with a balloon only. And I'm not a big fan of it, full disclosure. I rarely remember I've done this ever, honestly. And the reason being the following. Number one, the reocclusion. Okay, you think it looks pretty. You gave them 2B3 inhibitor. You did the balloon. Remember, this is everything we do is fairly temporary unless you secure healthy to healthy with a stent. Now, you already gave the 2B3 inhibitor. You already took the risk of accessing, right? So people get in trouble, one, from the blood thinners. Okay, you have a stroke that's already developed, and then you give the bolus. You have a hemorrhagic transformation. That's a troublemaker, right? Or two, you can't access, or you access in a not safe situation, and then you end up perforating, right? So if you think about it, by just stopping at the balloon step, you already gave the blood thinner, you already have the access, so it's almost no-brainer not to do the stent. Hence, we more so than not put these stents in place. As Dr. Rashid mentioned, there are a few of them. I personally not, although the wingspan is one of the ones that's actually studied for this purpose in a registry and in Sampras Enterprise. It's been kind of an older technology. Neuroform Atlas, I don't know if you're aware, this was developed mainly for stent assisting balloon coiling. I'm sorry, stent assisting coiling of brain aneurysm. So it's not like for that, but people get really nice results, and we collaborated with a lot of folks to show safety and easy deployment. And the Resolute Onyx, again, as Dr. Rashid mentioned, these are mostly coronary drug-eluted stents. It's a two-in-one, if you will. You just inflate the balloon, gonna do that, and then pop the stent open instead of going in and out multiple times. Now you ask, which one should I choose? Should I just is it an odd day, even day type of thing? Is it based on the measurements? Is it what? So again, this paper, and I try to kind of stick to this unless I'm out of the shelf, and I definitely kind of echo what Dr. Rashid, you sometimes have to use whatever you think you can or available for you at that day. So if the vessel, and I'll show you a couple examples, if the vessel is straight, think about it. If you have a balloon mounted stent that you need to inflate the balloon, so in a straight vessel would be easy. And instead of going through this, for instance, trying to have the balloon navigate here, balloon mounted stent, and then you stop here and then inflate the stent is very kind of tortuous for that. So that's kind of a no situation. So you would do that in a straight vessel. In a mismatch, remember, these are like you don't have, it's not like a carotid stent. Carotid stents are tapered. You have 8 millimeter to 10 millimeter or 6 to 8. Some of them are straight, 7 or 6 millimeter. Most of these intracranial, especially the balloon mounted, not especially the balloon mounted stents, they're usually just one. It's a 2 millimeter, which is the diameter of the vessel, by the second number is the length. So you have 2 by 15 or 2 by 12. 2 is the millimeter, the diameter of the vessel. The length is the second number. So if you have mismatch, so where do you do? Do you do it on here? Do you do it there? The problem with the balloon mounted stents, it will not pop out until you fully open the balloon. So let's say this is measuring 2 millimeter and this is like 1.2 millimeter. And then you go with a 2 millimeter because you want to seal, you want to close the mouth of the stent into the actual lumen of the blood vessel. So if you do that with a 2 millimeter, you have a balloon that's sitting here in a 1.2 or 1.3 millimeter. Can you imagine the problem? You can inflate a 2 millimeter balloon in a 1.2 vessel in an M2 or whatever, versus here is a straight, is a one single kind of measurement, as much as you can. Sometimes it's not easy. So that's like these are the nuances that you have to always factor in and think about before committing one way or another. So I'll, for sake of time, I'll keep cruising here. So this is M1 lesion. You can tell here my guide catheter higher up. You see kind of a little bit tapered looking, not the most tapered. It's not like Rumil's case where there was like an actual taper. It looked a little bit funny here. You put you put a stent retriever, and this is great picture. You can see that this is the stent sitting in the whole area, and then you can see the stenosis. This is a pause. This is where either the patient is already intubated. This is a whole debate on the GA versus monitored anesthesia with thrombectomy, but these are the cases that I'm really religiously have to intubate the patients, either after the first pass, or if I have a high suspicion that this is an ICAT situation, you would go with a GA from the get-go. And then you do the measurements. This is, I'm gonna just be quick here. I don't want to delay you all. So this is, here you go, coming up, a big J. I'm very kind of fearful of getting up into these perforators. So you cross with a J, and then this is the balloon. It's a balloon mounted stent. It's a very short segment. It's a 2 by 12 millimeter. You always go distal, because if you just parked here and then you push, you're not gonna go. You have just one way to go distal and then slowly come back. As you see here, I came back eventually. And then The next step is slowly inflates, and this you're gonna see the stent pot is gonna, you see this wasted. This is literally where the problem, remember on the actual angiogram, there's a waste and the beginning proximal and distal fairly healthier, but this is where the waste is, this, and then pop it open nicely here. Then you leave the wire, as I said, just you have a wire access. So in case you need another stent, etc., you don't need to walk around with a freshly placed stent. And then you see this very kind of short area, and then you see a nice result here afterwards. Very quickly here again, I don't want to, this is a Basel from a week ago. I was suspecting that on the CTA, very kind of irregular, unhealthy looking lesion. Another one pass in there, but you can tell where I'm going with. Remember that figure that I just showed you? Is this as nice as a straight as the one that we had? Absolutely not. You see this curve. So me trying to put a balloon mounted stent here is probably harder. But again, this is a stent placement. After the stent retriever, rather, got nice results. It's open. It's not healthy, you can tell, but it's there. Then I got worried about this, like P1. Is this like a competitive flow? Right here, let me just show you quickly. Is this a competitive flow? Is this an occlusion? Do I need to do a pass in the PCA? What's happening? So what I did is we need to remember, I didn't give anything at this spot now. It's like basilar occlusion, and maybe there's pontine stroke. People cannot get away with it. So trying to avoid that. So quickly went to the ICA to want to make sure that the PCA is fetal, which turned to be the case here. You see the fetal PCA right in here. There's a lot of ICAD, but there's the PCA entirely open. So it's like, okay, this is, I shouldn't be worried about the PCA here. So I'm happy we'll stop here. On the way out, I wanted to look at the how it looks, and sure thing, look how it looks now. Again, reocclusion. I ended up giving the patient load, putting a self-expandable stent this time, plasty it, and then put a stent, and you can see here the stent in place. Okay, quickly, these are the last couple slides. The stent, there's like this newer, I don't know if you all have it, sometimes there's a one, remember the balloon mounted stents, the advantage is you have one access, right? You go there, inflate the balloon, pop the stent. There's a certain type of a balloon that you can actually push the stent through it. So you can plasty, pop it open with a balloon, and then take the wire and then push the stent. We published this, our result, through the balloon. This is a deployment of a stent through an actual balloon angioplasty catheter. Okay, so I didn't have to pull the balloon out and then reaccess with a catheter. This is, I'm putting the stent here through this. So essentially 2-in-1 essentially. All right, I'm gonna have to close here because I want to be respectful to my other colleagues. This is a plug to what we're doing with Mission Thrombectomy and with all the teleeducation, and Fawaz and team been working tirelessly on this initiative. So thank you again.
Thank you again, Dr. Al-Hamza, for very, very comprehensive presentation. I'm sure there will be a lot of questions, and I just remind the audience and attendee, we have more than 350 attendees so far to put their questions in Q&A, and hopefully we'll get to this. We started with a case and we'll end up with a case, and it's my honor to introduce our superstar fellow, Dr. Mohammed Al-Hashmi, who's a neurologist from Al-Kuwait, and he is with us now for the second year in the stroke fellowship, and he is interested to become also an interventional neurologist. Dr. Mohammed, the floor is yours.
Can you hear me? Yep.
Yes, we can.
All right. Thank you. Thank you for the introduction, Professor Adel. and thanks for the invite and the opportunity to present these cases. So I'm just going to go through a couple of cases about rescue stenting and angioplasty that we've come across in clinical practice. And for each case, there is actually a theme. And how did we spot the ICAD? Well, most of them we spotted the ICAD before actually proceeding with the thrombectomy or during the thrombectomy, but some of them actually were taken back to the angio suite. So I want to ruin the surprises. So we'll start off with the first case. It's a 53-year-old male with a history of smoking and hypertension. The patient was last seen at 1 a.m., woke up at 6 with left-sided and hemi neglect. Overnight, the patient actually presented to another facility and then transferred to our facility for intervention. And when he presented to the initial facility, he did not receive thrombolysis. He was actually outside of the window, and his NHS at that time was actually an 8. So this is his aspects or CT scan, negative CT scan for any obvious hypodensity. So at the beginning, he had a good aspect score, and this is his CT perfusion. So there wasn't actually any core and you can see that there's actually a huge penumbra with the Tmax 6. It's actually 236. We can see it over here highlighted in the green area. I don't have a video, so I brought in screenshots of the CTAs to save time actually. And over here we can see that the patient actually has a right proximal M1 with underlying ICAD, if you can see over in the other artery, the other MCA, as well as the right MCA. You can see ICAD all over the place actually. So the patient was taken to the angio room, and at the beginning he had a single distal aspiration and no intra-arterial TPA was given for the patient. Another pass was done through the stenosis using Dodge's angioplasty, and it actually resulted in improvement of the stenosis to less than 25% of the narrowing, and it was durable for the next 10 minutes as well. So we had another angiogram afterwards to see whether it would actually collapse or not. At that time, we decided to actually give the patient the best medical therapy for his ICAD at that time. So we initiated an IV integral, a glycoprotein IV molecule, and the patient was then eventually loaded with aspirin and clopidogrel at the same time while he was on that infusion. So we were giving the infusion some time to cover for those 2 agents until they actually kicked in after the loading. So the patient was taken into the neurovascular step-down unit. He's in the stroke unit. He's being monitored closely. And 2 hours later, as part of the monitoring, we noticed that the patient's NHS actually started to worsen. It became 12. So stroke code was actually reactivated again for the same patient, and it showed an occlusion of M1. So he re-occluded again, and you can see it over here in the right M1. The patient has a small core and a big penumbra once again with a mismatch ratio of 14.1. So the patient was retaken again to the angio suite, and a successful recanalization actually happened after 1 pass, and it revealed the focal irregularities. We can see it all over, and we can see it over here also as well in the M1. So a triple stent was eventually placed for the patient with distal aspiration, and it resulted in re-establishing the anterior grid flow at the occlusion. But the patient didn't receive IA as well at that time. So eventually the patient was stented, so successful wingspan stent deployment, and it improved the distal flow and the thickness was achieved. So the theme for that case was always be vigilant and always monitor patients, especially when you're suspecting underlying ICAD or have ICAD. The second case is a patient who's 36 years old and was actually playing basketball when he developed his symptoms. So he was playing basketball, developed right-sided hemiplegia, some dysphagia, and a partial gaze, taken to the hospital with an NHS of 12. He was outside of the window when he was taken. And once again, this is a patient that was transferred more than once Actually, he was transferred the first time via an ambulance to the first hospital and then to another facility and eventually to our facility. So he was transferred 3 times. And by the time he reached, it was around 7 p.m. and his onset was at 10:30. This is the aspect score. It was perfect, 10. And over here, we can see a left monocclusion as on his CTA. So this is a baseline angiogram before we actually started. And we can see how the patient actually has his left M1. And then angioplasty with distal aspiration, and that resulted in re-establishing the anterior great flow at the occlusion. However, 10 minutes afterwards, after the first angiographic run, he re-occluded again in the follow-up run. And we can see that in both the lateral view and the initial view that I had on. So systemic loading with integral and deployment of a drug-eluting stent was done, and that established the flow immediately for the patient. We can see the stent over here as well. So the outcome, the post-empty straight away, the NIHS was actually a 5, and 12 hours afterwards, he was improving still, and it was actually a 3. And the patient returned to the transferring hospital. The third case is quite different from the other 2 cases. It's a 51-year-old male who was actually maintained on dual antiplatelets, i.e. aspirin and Plavix, due to a previous strokes 2 weeks prior to presentation for right-sided hemiparesis and vertigo. He presented to our facility with aphasia and hemiplegia with an NIHS actually of 18, and when he presented, fortunately, he was outside of the window for thrombolysis. A CT scan was done for him at that time alongside the CTA, and 12 hours after his initial CT scan and CTA, and despite being on dual antiplatelets, he actually worsened, developing quadriparesis, and his NIHS score was actually 21. So stroke code was activated at that time, and the patient eventually was pushed for EVT. But prior to moving on to the intervention part, I'll just go through the images because it's quite actually interesting to see the results of the imaging for this patient. So we can see some hypodensities on his CT scan, and it's actually a posterior circulation stroke for him. Over here, we can see the classification of the severe stenosis or the proximal basilar artery on a coronal CTA. However, during his perfusion parameters, we can also see that the patient has a high Tmax 6. It was 134 and with a mismatch volume of 134 as well. A stat MRI was also asked for the patient. However, his flares were normal, but his DWIs were not. Oh, sorry. Got a couple of MRI cuts over here just to see at different levels, and taken to the angio room finally. So the angiogram at the initial phase, it shows the occlusion of the basilar artery, and over here it shows the severe stenosis, like pointed with the arrows. And this is the pre-stenting of the patient, and the lateral view after we were done. So it shows how reperfuse or the reperfusion of the basilar artery. So pre, during, and post. So I'll just conclude with patients who actually have ICAD. Always be alert and prepared for the worst, to be honest, and for using stents, always have glycoproteins available because you might use them during the angio, and eventually you will use them if the patient has ICAD. And that's it.
Thank you very much, Dr. Mohammed. very nice illustrative cases, and I would like now to invite Dr. Ayman, my co-moderators, to moderate the Q&A. We have already a couple of questions from the audience. Dr. Ayman, if you have
Thank
any
you.
comments or suggestions.
Thank you, Dr. Adel. Thank you, everyone. Thank you, all the speakers. It was very interesting topics and very informative. And thank you all for your wonderful presentations. I'm looking at the questions. So let's start with the question to Dr. Abdullah. There's a question saying, do you routinely give nitro or verapamil before angioplasty or stenting, and do you wait for the response?
No, actually, rarely we give nitro or any vasodilators.
Okay. Thank you. I'm just reading the question, looking at the questions here in the Q&A section. There's the questions on. There's a few questions regarding anticoagulation. So maybe with Dr. Singh, what protocol exactly do you use when you're for anticoagulation when stenting? Like, is it integralin, and for how long is the infusion, and when do you start dual antiplatelets?
For dual antiplatelets, I think basically what you try to do is integralin is on when the stent is put in. So I mentioned in my answers to a couple of people as well. So it depends on the IR physician on when they want to overlap. Ideally, what I have seen is that they would want to overlap with aspirin and Plavix, or if we know a PRU from before, it can be either platelet reactive unit or P2 at 12 level. If it's really high, that means the patient is not responding to Plavix. So if you start a patient on Plavix, after integralin, the stent may shut down again. So we do Brilinta instead. So we either load the patient with 600 of Plavix or 180 of Brilinta. If you're doing Brilinta, we start patient on 90 BID. And if you're doing Plavix, it's 75 milligrams standard dosing. We do it for 3 to 6 months. We see the patients on 3 months after the hospitalization, and then decide whether the patient should continue taking these medications or not. The patency of the stent is always checked afterwards in the clinic. Either you can check it by the TCDs with the flow velocities, or you can always get a CT angiogram. But ideally, what I have seen is that people, most of the times, they overlap IV antiplatelet therapy with oral, because all the standard half-lives are different for all the medications. But sometimes people have done is that they have stopped integralin at like hour 10, and at hour 10:05 we give the loading dose. However, there are like bunch of factors, because most of the people who come with big strokes requiring ICAT therapy, they cannot swallow. So you cannot really give them Plavix. You have to put an NG tube in. So ideally, you would keep the antiplatelet IV therapy for a longer time. That is my perspective from a fellow's point of view, but from an attending's point of view, I would ask them what they have done in their practice.
So, Bayati, do you want to share your thoughts on this? Because there is a lot of questions on antithrombotics regimen, both with IV TPA and without, because all of those cases did not receive TPA, luckily. So when TPA is on board, and then the other question: if you suspect ICAD and it's at the spoke hospital, you feel comfortable skipping TPA when that's the case, because we're not 100% in predicting that. So what's your take on this?
Yeah, so this is an excellent question, and very, very moving target, right? Like nowadays we have extended window, so we're gonna have more of these patients that potentially have like a TNK on board. My 2 cents, and it's easy for me, let's say my colleague who is on the stroke call, for instance, I rarely do both at the same moment, almost never, unless like I'm on telly and I'm on attending, like very rarely. But it's easy for me to say to my colleague, well, I don't want this patient to get TNK, but it's unfortunately their own decision, right, for a stroke physician. So that basilar person that I showed, he was in the emergency room, and I suspected it, and then he was in the window, and we held it, and luckily we did well. For Spoke Hospital, absolutely not. We do not have any ground to say hold that the TNK or the lytic alteplase, whatever. Especially the bridging, we show over and over that there's safety with it. And this happened not like the more common situation is actually not the ICAD, is the carotid stent. Any tandem lesion, the same amount of, yes, we're more kind of cognizant and very kind of anxious about the antiplatelets with an intracranial stent. All these stents that the whole speakers show, they're very short, they're very small. The odds of them reocclusion is way higher than a big carotid stents, right? So we're not talking about the same situation. But yeah, so that's about the thrombolytic. About the post-op care, again, as I said, I'm evolving as we go. So since I'm putting everyone to sleep, I used to like get anxious. Oh, let's extubate, get worried about the exam and all this. It's not going to change. Okay. We have a patient intubated. We're going to have a good moment to put an OG. The anesthesia colleague will be much easier to put an OG, track the tube than putting a patient who's phasing and fidgety and kicking and put in an NG tube upstairs in the ICU. So we put the OG, we don't do anything with it. We take the patients next door to a CAT scan. We do something called dual energy CT, which should have like a certain protocol. I don't know if some of you guys might have it. I certainly did not have it in Emory. In Atlanta until I moved here, and I have it here. It's very helpful to delineate between contrast and blood. And if that's good, then as Ramil said, at that point, I will give the loading dose. Some of the attendings will want like another 2 hours of infusion kind of in the meantime. I personally don't, again, because I'm just a little bit cynical about the care for the infusion rather than the actual itself. So as long as within the hour, because we already, as I showed, is typical, the half-life is 2 hours of the bolus. So as long as you get it within the first 60 minutes, I think we're good. If there's no access, if the Brilinta is out of the whatever Pyxis pharmacy issues, then I start the integral infusion after a good CAT scan.
So for the audience in the Middle East, so Brilinta is ticagrelor. And in our population, we have 20 to 25% of Plavix resistance. So many of the interventionals just, go for Brilinta now. And, I want to take, what's Dr. Abdullah Rashid take on this? You still prefer to use ticagrelor aspirin combination, or you prefer the switching to ticagrelor, not to risk the, Plavix resistance?
Exactly, yes, Dr. Adel. This is what we are doing now. We prefer to use Brilinta instead of Plavix.
Okay. Dr. Ayman, I don't know if there is still any questions unanswered.
No, I think they were mainly around the same topic. Most of them were about, I'm just looking through them, most of them were about the anticoagulation. There's a question here, is if there was if the patient had a stroke and there was carotid stenosis after treatment, will you consider surgery or stenting? That's one of the questions we have here. Otherwise, everything is about anticoagulation, which we answered, I think, by our speakers. Anything else, Dr. Adelius?
So prophylactic using the nitro or verapamil, before doing this, there was questions. I think Dr. Abdullah mentioned he doesn't use it unless there is a vasospasm. What about you, Dr. Hamza? There was another question about that.
Yeah, so I actually do. And just because I don't do nitro, I'm not a big fan of nitro because it drops the blood pressure very quickly. I use something called Melanon. You might be able also
Yeah.
use that. It's a positive inotropic agent, so it doesn't only vasodilate, but it's also activate and have the only side effect with it, something that I'm very becoming more and more kind of apprehensive about, is the tachycardia. If the patient is already in the 90s, 100, giving Melanon might even make it worse. But otherwise, typical patients, Melanon, I give it while I'm putting the stent. More so than not, I do that regularly. I put the stent retriever in place. I give like a few milligrams, 3 to 5 milligrams, if the blood pressure is able to tolerate. I start very slowly. I put my timer 5 minutes anyway, so I slowly give it, even if it's not ICAD. Just kind of there's good safety data on it. And especially I give it in the carotid, like from the big guide catheter anyways. And sometimes you have like spasm in the carotid. So it's fairly benign medication. But that's also in an ICAD, that's kind of tell you that if there is like potential ICAD, will be helpful to have a better lumen to go through. I'm just thinking 2 steps ahead. If it's ICAD and you have a spasm on top, I give this vasodilator to hopefully give me an easier access with the wire of the balloon. But I don't like keep giving until open, no, just with when the stent retriever is in place.
Thank you. There's one question about when to calculate the size of the stent or submaximal angioplasty. Any tips or tricks? And then another question about the NIH cutoff for ICAD patients with symptoms without occlusions to intervene.
So,
Dr. Abdullah, you want to do the sizing and then?
yeah, generally we do the sizing in the angio suite on the machine itself, because our machine does the auto calibration, or you manually calibrate the vessel, the images. But in general, we tend to use a smaller stent for the M1. A little bit larger for the ICA, like 3 millimeter for the ICA, 1.5, or if it's big enough, you can go up to 2 millimeters for the M1 and the basilar, but always under deflate the balloon.
Dr. Hamza, do you have any?
Yeah, same thing. Especially all the nuance, as you can tell by now, it's all the anxieties about the balloon more than the stent, right? Whether you're going to go the balloon angioplasty, as Dr. Rashid said, most of these I do it with this, as I showed a couple of pictures, when the stent retriever is up. You can tell how long is it, you can measure all this. So this is all about the balloon or the balloon mounted stent, right? Because the balloon, you just don't want to go higher than what you're supposed to. For a self-expandable stent, whether it's a wingspan or an atlas, I actually keep it very simple. Big and long. Long, obviously, you don't want to dangle in the ICA if it's in the M2, you don't need that. But big, the radial force of 4.5, which is the atlas, the biggest atlas is 4.5, is actually proven has more radial force than a 3 millimeter atlas. So I typically go with the biggest atlas I have on the shelf, and then the length typically doesn't foreshorten, so I just lay it across that area. But I don't tend to, like if you have a mid M1 or a proximal M1, I don't want to end the stent in the M1. I typically kind of have, because you will have potentially a peristenosis, restenosis, or peristent restenosis. That's potentially an issue. So I try to go very healthy to length.
Okay, we are at the time. Just I want to highlight, a few things. We're talking about rescue EVT stenting because some of the questions about secondary prevention, about extracranial or intracranial. For that, refer to the guidelines. If it's intracranial ICAD, generally would go with the medical management. I think most of us would agree on this. And it fails, you go for revascularization. And for extracranial, again, I would refer you to the recently published American Heart Association, American Stroke Association for which one to go for surgery, because there was questions versus stent. And also, before we conclude, I would like to again invite all of you to our MENASO annual meeting, which inshallah going to be in Kuwait, and hopefully all this nonsense happening, inshallah it will be clear. Then we'll celebrate the science, inshallah, in Al Kuwait. So looking forward to meet all of you soon. Thank you for your for the speakers for an outstanding presentation against very nasty disease. And I'll give the mic to Dr. Ayman to close and conclude.
Thank you, Dr.